What's up, guys? Thank you so much for checking out today's Case by Case with Power Metal Performance. I'm here with Aaron Miller, who is a fellowship trained manual therapist, and he's just going to take us through a recent patient that he's had some time with now, and he hit some of the highlights of his assessment, his treatment progression, things of that nature. So he'll walk you through it. The whole goal here is that we are able to possibly provide you with an alternative approach to how you approach things in the clinic. Yeah, man, Aaron, if you wouldn't mind getting this rolling here, I think that'd be awesome.
Yeah, thanks, Devin. Appreciate the intro there. So the case is going to dive into your typical evaluation that you might get from a referral source that says, shoulder pain or impingement or something of that nature, or rotator cuff impingement. But one of the major ones that we see, Tevin, and really kind of, I think, is like a hot topic word for a diagnosis, is this whole idea of scapular dyskinesia.
Sure.
I'm sure you've heard that term in your career, and
yeah.
Let me ask you, what are your thoughts on scapular dyskinesia before I dive into the case?
Well, even as a student, and anytime I've heard scapular dyskinesia, I've never really understood where we're trying to go with that. It basically just sounds like it's a shotgun term for there's something going on with the scapula with certain movements. That's all that really sounds like to me.
Yeah, I think that's what people mostly get out of, is that there's something that's not moving right with the scapula, but we're really not sure how to define that, right?
Exactly.
So with that being said, this is, again, my kind of approach on this whole scapular dyskinesia, and what I call is more so a scapular dysfunction, because I believe that there are defined movements that can let us know what is going on with that scapula. And I think that there's two reasons why we get this scapular dysfunction. And this is in the presence of no trauma. So obviously, if you fall on it, like I did mountain biking, you might have some issues with your scapula. But in the presence of no trauma, I think that there are two positions that I see most of the time, and surely some of them will probably be able to find like 100 of them, but different movements and positions of the scapula that we see in the clinic. So in this case, it's middle-aged female, comes in to see me, shoulder pain with radiating symptoms down the arm. And I'm sure that describes a lot of the shoulder pain that you see, right?
Majority, yeah.
Yeah, majority. So it's our job, like you said in the beginning, to give us an alternative approach on how and where to start with this population. So first and foremost, man, and I don't know how much time you spend looking at posture and just static position of a patient, but that's super important to me. That's where I define what is actually going on. I don't know, do you spend a lot of time looking at that with your patients?
I personally, I do feel like if we wanted to dive into static positioning, posture, that sort of thing, I think that can be an entire hour in itself, because I feel like that's actually kind of a hot button issue in our field. Also, some people don't think it's important. Some people seem to think it's super important. I kind of lean towards it's important, and it's where I start. So I do spend some time on that.
Yeah. So this patient, when I look at their postures, I'm the same way. I maybe when I first started, I didn't know how much posture actually weighed into my PT diagnosis or treatment. But since going through the training and through fellowship, really I've defined kind of this postural position. And you look at the shoulder blade position, right? And if one side is hanging down or abducted or internally rotated or depressed or elevated, or however the position, I think that matters, especially if it's the pain provocating or symptomatic side. So personally, this female came in and her shoulder was depressed. You look at the shoulder blade, it was hanging down and kind of tipped out. Okay. So that's important to me. And you got to ask yourself, why is the shoulder blade in that position? Right. Because that's what it's all about. Because an easy test that I did with her, Tevin, was I just took that shoulder blade, passively elevated it, and it did several things. It started to alleviate the sensation, the pain in her arm,
Okay.
as well as it improved her active range of motion. just by keeping the scapula in an elevated position.
A pretty solid test, retest right there, just to get
The,
rolling.
the proof's in the pudding, right?
Yeah, there you go.
So now we know, right? Does putting it in a passive position improve their symptoms, and does it improve their mobility? If the answer is yes, then you've got to go, well, what caused the scapula to be in that position in the first place, right? Is that where your mind goes, or
Yeah,
would you just start treating, serratus and all these other parascapular muscles that are surrounding
obviously
it?
we're hitting the infraspinatus first, and then the serratus. No, before we keep going here, I actually really want to hit on one thing. So when you said
Yeah.
posture was important to you, you dived into, or you dove into, the position of the scapula. You didn't just say, oh, this is an upper cross syndrome, like you'll hear a lot of people go for. You're actually looking at certain landmarks, at certain movements.
Yeah.
And I think if we're trying to be movement specialists, I personally feel like that's important. So I just wanted to hit on that because I thought that was pretty cool. You broke it out like that instead of saying something super generalized at this point. So
Well, I mean, if we want to get people not just better, Tevin, but better, I think we have to understand the underlying issues that create these postures, that create, not just saying they have this broad diagnosis and then just treat everything, have them do chin tucks and have them, pull their shoulders back. I mean, everyone's always telling you that, right?
yeah,
But why are we doing that?
it's the fun part, but that's the tough part, man.
Yeah, yeah. So, you know, uh, the other thing, the other position of the scapula that I find, so that's the first position, and that's that in that case with this patient, it was a depressed scapula, right? Um, so I've had cases. Tevin, I believe I was talking about that, how my patient presented with a depressed scapula, or that side hanging down a little bit, but I really kind of want to dive into what creates that. We talked about finding the cause of why that position is so important, because it can lead to so many other diagnoses. And again, in the presence of no trauma, I think we have to look higher. We have to look central. We have to look more so in the neck. And the reason I say that is because if you have a chronic injury, a chronic movement impairment, uh, chronic dysfunction of a segment in your cervical spine, whether you favor a movement, you move one direction all the time, whether that's just the postural positions of holding your head forward at a computer for 8 hours a day, the stress points in your neck will actually cause some, for sure, issues at the joint. But more importantly, and this is what I've seen all the time, is it affects the nerve, and the compression on neural tissue is what kind of strangulates that nerve. And that's what can either send a muscle to kind of like I describe it as a hose, right? A water hose. If you step on the water hose, you're not going to be able to get the water to feed the garden, right?
Sure.
So if you have some compression or some issue or dysfunction in your neck that's compressing that nerve, it can't feed the muscle. So it just kind of falls, because your scapula and shoulder blades only attached in one point. That's in the front. Everything else is controlled by your musculature
Kind of
and
flow.
ligaments. But
Physiological joint there.
that's right. It's the only skeletal connection, right? So everything
Right.
else is driven by the muscular tension and the movement, right? So in this case, I feel like, and when I did address cervical componentry movement, improve that, improve the neurovascular supply, then in retraining those muscles that all sit around the scapula, boom, came right up to where we know if we can get it passively, it takes away her symptoms and improves her movement. So
That's a tricky thing though, because a lot of therapists aren't comfortable treating the neck or the nervous system itself, so the nervous tissue. Um,
yeah,
so
but we need to be.
yeah, right. Can you just briefly give us one movement or manual technique, just something that you specifically did for the cervical spine, just where one specific thing, just to give people an idea of what you're kind of going for.
So you're talking about at the joint level,
Yeah,
like at a technique, manual technique?
just any movement or corrective movement or manual technique.
Yeah, so I'll give you kind of a manual technique followed up with a corrective movement. So
Okay.
this patient in particular, forward head. So we had some compression at around the C5-6 interchange of her spine. And the problem was is it could not go, it was stuck in extension, could not go into flexion,
Sure.
right? On her affected side, on her right side. So what I did was did an opening manipulation, on that level, safe. I ruled out all the red flags, asked all the right questions. She tested negative for any major ligamentous injury or insult, and she was comfortable doing it. So I did a manipulation there first, okay, and then the follow up is how do you then keep that joint being able to flex and not go right back to extended position? And that's when I put her in like kind of a flex position, okay, like that, with that chin tucked in, and I held her head and monitored the facet joint with my other hand and started to let go and had her hold her head in that position until I felt like she was losing it. And that was like 3 or 4 seconds to start.
Yeah,
And I
right.
was given 80% of the help.
Right.
So
So
basically, I'm trying to wake up her anterior cervical muscles to hold the spine in that position.
that's awesome, but you got to be able to feel that, right?
Yeah, gotta be able to feel it, and that comes with practice. And if you don't know how, find someone who can and learn from them.
Sure.
Mentor. You and I have both been through fellowship programs, but it just takes someone who's willing to invest their time in getting you better, so your patients can get better.
I think that's one of the biggest things for any new graduate coming out, especially, is to find somebody they can consistently learn from like that, because that's a very specific technique, but
Yep.
usually pretty beneficial if you identify the movement impairment and kind of run with it from there. So
Yeah, because people ask me all the time, why don't you work on the shoulder blade? Well, if this doesn't get stronger first and able to hold, you can beat this up all day and it's not going to get any better. That shoulder
right.
blade's still going to be hanging low.
You're gonna be hitting the reset button constantly, day to day, right?
Every time. Every time. And with that treatment technique, you should see results in what, 3, 4 weeks in pain, movement, strength, neuromuscular control, all of it.
That was actually my follow-up question for you: is how long would you tell somebody that you should see significant change in all of those things you just listed?
Yeah. I mean, I want to see them first day, to be honest with you. I think you can make a change the first day, no matter how small, but it's that change that lets your patient have hope that they'll improve in the allotted time that you've given them. Now, I think it's all relative to if a person comes in with having chronic pain versus acute pain, but you can stagger your healing phases and rehab phases based on that as well.
Sure. Well, Aaron, I think that's the time we have for this round of the case by case. Man, is there any extra notes, anything else you wanted to add real quick that we didn't have time to get to?
No, I mean, the last thing that I would say is if some of these techniques are foreign to you, if you don't feel comfortable with them, truly, and I say this all the time, is invest in yourself as a therapist, because the difference is markedly noticed in treatment and how your patients perceive what we do as physical therapists as well. So really, if you don't know, dive in, because this is really important stuff and stuff that's not seen enough in the clinical setting. So
And it helps us help more people. So also on that note, if you have any quick questions, you can just hit us up at Power Performance on Instagram, or info@powerperformance.com. As well, just shoot us a quick email, a quick message, and if we can help, guys, we definitely will. That's what we're doing all this for. So, Aaron, thank you so much for your time, man. I really appreciate it. Yeah, and thank you guys for checking this episode of the Case by Case series out. Hope it was helpful. Please leave us some feedback. We have a Facebook page, Students for PT. I think that's the correct title, right, Aaron? Am I saying that right?
Students for physical therapy. Yep.
Yeah, students
Or students of physical therapy.
That's the part I was like, I said it and I was like, that doesn't feel right. So
Yeah.
students of physical therapy, trying to get some conversations in there. So guys, thank you so much again. Please let us know if you need anything. All right, bye.